So anytime we treat breast cancer, it is a multidisciplinary or team-based approach. Our patients receive a combination of surgery, radiation therapy, and systemic therapy or treatment of the whole body. So in the setting of surgery, we have options for breast conservation or mastectomy. Now, breast conservation or lumpectomy, that's where we remove the cancer, keeping the breast intact, and we remove the cancer with a normal area of breast tissue surrounding it. We call that normal area of breast tissue a margin because we like clean negative margins to confirm all that cancer's been removed. And I like these two pictures because as I mentioned previously, these are two things I generally don't do. One, I hardly ever put my incision directly on the breast. It's around the areola or the outside of the breast. And the other picture showing a defect in the breast tissue. And that's where my oncoplastic training comes in, where I'll rearrange the breast tissue to minimize any visible deficit. So while treating the cancer is ultimately our primary concern, leaving a beautiful result is really my secondary focus. And then the other option is a mastectomy. This is removal of all of the breast tissue, in some cases also the skin and nipple, leaving a scar across the chest wall. But of course, there are multiple options for reconstruction. And this is another side where that oncoplastic term comes in, because women where it's appropriate from a cancer standpoint, where it's appropriate from a blood supply safety standpoint, we are preserving skin and nipple with mastectomy, so women can keep their nipple, keep their skin, and have a reconstruction just underneath it. And I get asked all the time, so Dr. Jacobbe, I get asked at like cocktail parties, so tell me, lumpectomy versus mastectomy, really which would you choose, which is best? And this is where I like to get on my soapbox and say, 25 years ago, we had data that showed when we had a lumpectomy, and I might come back to this, but when we had a lumpectomy versus a mastectomy, which was better? So years ago, overall survival was the same. So we could choose one or the other and the survival will be the same. But risk of recurrence was different. So when we had a lumpectomy with all of its treatment, the risk of recurrence was about 5%, mastectomy about 3%. However, at the time we were comparing apples to oranges to pineapples. We're all breast cancers to all breast cancers. We now know that in comparing apples to apples and the same breast cancer to the same breast cancer, overall survival is still the same, but the risk of recurrence is almost identical. So it is much more about the actual breast cancer as to whether or not it will recur versus the surgical treatment type. Yes, we want to remove all of the cancer, we want to do the appropriate safe treatment, but now it becomes a choice. And this is where that oncoplastic piece comes in, where we get to have a conversation with each individual patient of what is your choice, what works best for you. And I might go into that a little bit more later. So the next piece to the puzzle, radiation therapy. So radiation therapy is always part of the treatment plan with breast conservation. So when we do lumpectomy, radiation therapy always follows. This is part of what allows lumpectomy to have those same rates as mastectomy. Now, radiation, it's just a beam across the chest wall, and we have a cartoon as well as the actual picture of what the machine looks like. And it is a beam of radiation, comes across the chest wall, sometimes also treats the armpit. Now, we do a radiation with lumpectomy because it decreases the rate of in-breast cancer occurrence by up to 50%. Big number, that's why we do it. In the setting of mastectomy, we don't always do it. There are lots of rules and reasons why we would or would not, but the decision generally gets made after surgery when we have all of the information back. Now, that last piece to the puzzle, systemic therapy. On one side of things, we have the anti-hormonal or endocrine therapy. So for the tumors that have those estrogen receptors, progesterone receptors, we have a pill. We have a multitude of pills, but one in particular for each patient that will block those receptors and treat the cancer. And on the other side of things, we have chemotherapy. Now, 20 years ago, every patient with a tumor over a centimeter got chemotherapy. We just treated everybody all the same, apples, oranges, and bananas. However, we now know that whether or not a tumor needs chemotherapy is based on the makeup of the tumor itself. I have that little line down there, Oncotype DX. That's one of many tests that we use that actually looks at the tumor, what genes are there, what genes aren't there, to determine if chemotherapy is necessary and beneficial for the patient. But I do like to say that every patient with breast cancer gets something to treat their whole body. Some women just get the endocrine therapy, some women just get chemotherapy, some women do get both. And also those are the rules, and of course there are exceptions to every one of them when it comes to treatment.